All right, thanks, Ernie. Back to PAO. Thanks to everybody for sticking around this afternoon. My disclosure is really not pertinent for this particular talk. So we know PAO has become the dominant operation for symptomatic adolescent and young adult dysplasia across the world, really. There is a recent movement towards less invasive surgical approaches for PAO. And there's also a recent movement, as we heard a lot of discussion yesterday, about the potential for combined hip arthroscopy and PAO either at the same setting or at a staged setting preoperatively, primarily to address intra-articular pathology and head-neck offset on the femoral side. And so this is really the debate. Now, for the first 12 years or so of my practice, largely influenced by Jeff Mast, who helped me learn this operation, I opened every single capsule. I had a frequency of doing head-neck offset in over 80% of the patients. And in about 2012, I stopped, largely influenced by the experience of guys like Jeff, by Joel Mata and Kjeld Sabali from Denmark, who were not routinely looking in the joint. I stopped, adopted a more rectus-sparing approach to PAO, and stopped looking in the joint in the vast majority of cases. This is the debate now. Combined scope and PAO has some potential advantages, and PAO alone has some potential advantage, mainly preserved tissue planes, potentially a little bit greater safety. And so it led to the question of what is really the subsequent rate of hip arthroscopy after PAO if you don't look in the joint. There was some earlier literature from Mike Millis's group that suggested about an 11% subsequent scope rate at 9 years in the Boston series, and then a very large, more recent series from Kjeld Sabali's group, over 13,000 hips. Interestingly, the exact same 11% subsequent arthroscopy rate. And so this motivated us to look at our series. So the primary outcome that we wanted to look at was the incidence of subsequent hip arthroscopy after rectus-sparing PAO. We wanted to see if we could predict factors that would lead to the subsequent scope. And then the secondary outcomes you see listed there, survivorship, PROM, and radiographic parameters and complications we wanted to look at as well. So this is the methodology. This was an IRB study looking at my rectus-sparing cases from June 2012 to March 2022. That was 349 hips. We excluded 4 PAOs that were done either with combined scope and or an arthrotomy for rather specialized femoral morphology, all done by me at a couple different hospitals. The rectus-sparing technique is of interest. I've heard several folks ask me about that. I have some videos on the rectus-sparing technique. Just due to time, I'm not going to show the whole thing, but to suffice it to say that the direct head of the rectus is left intact during this operation. Anybody who wants to take a look at this video, I'm happy to share that with them. In terms of the methodology, and in addition to contacting all the patients, which we did except for approximately 8, we searched 2 electronic medical records at the 2 largest healthcare systems in our area and cross-matched patients who had had surgery at one of these 2 hospitals to make sure that they hadn't had a subsequent surgery. The demographics of the entire series are shown here. So it's pretty typical, 88% female patients, typical age range 24, BMI 24.5. This is really the take-home slide, the results. We had a 4.6% rate of subsequent hip arthroscopy in this group. Interestingly, almost 30 patients, or 8%, had had a hip arthroscopy prior to their PAO, which to me was a lower number than I expected. And we can talk a little bit about that. But 1 hip was converted in this series to total hip, and there's been 1 revision PAO for insufficient correction. When we look at the results broken down by demographics, there's really not a difference between males and females in terms of who went on to have a subsequent scope. 4.5% in females, 5% in males, and then really no other demographic factor that correlated with the need for a subsequent scope. When we look at the time to subsequent hip arthroscopy, on average, it was 2.5 years, the earliest being right around 1 year, all the way out to just about 6 years. These are the pre- and post-operative patient-reported outcomes, pre-op in blue and post-op in red for the entire series. And you can see the important facets are shown there on the right, we had a substantial reduction in pain, and the Hoos Jr. score improved substantially for the entire series, as you would expect. When we look at the post-PAO scope versus no subsequent hip arthroscopy, the no arthroscopy series is shown in red, and the scoped hips are shown in blue. Again, what we see is that the scoped hips tended to have more pain and a lower Hoos Jr. score than the hips that did not undergo hip arthroscopy. When we look at the scope after PAO, the pre-scope and post-scope PROs, not much difference between the two, except physical function was slightly lower in the pre-scope patients. The data gets a little bit cumbersome here. We had obviously there's a small number of patients who underwent hip arthroscopy. This is the patient-reported outcomes over time, comparing those who had had a scope after their PAO. And what you see again is that scoped patients tend to do slightly less well than those who did not undergo a hip arthroscopy. And this is looking at it again in a slightly different way, but essentially showing the exact same finding. And this is, again, pros between patients who had a pre-PAO scope, no scope, and those that had a post-PAO scope. And on the far right, really what you see is those who, in terms of Hoos Jr., those who had had just a PAO alone tended to have the best scores in both compared to the other two groups. In terms of radiographic evaluation, we looked at the pre-op PAO and the post-op PAO radiographic metrics that we typically look at. And there's really not much difference between the two groups. So they started with about the same amount of dysplasia, and the amount of correction that we achieved in both groups was very similar. The only really finding of importance here is that the alpha angle was slightly greater in those patients who underwent a subsequent arthroscopy, with an average of 46 compared to an average of 43 in those who did not undergo a subsequent hip arthroscopy. This is just a case example. It's a little bit of a complex case example. This is a 21-year-old female. She'd had 3 prior right hip scopes. You can see in that center false profile image that there's probably a little bit of iatrogenic removal of cartilage anteriorly. She had symptoms of instability, was fairly miserable. We did this right PAO. She did fairly well after that. She wanted her left side done. She said she absolutely did not want to consider having a hip arthroscopy on her left side. And so we felt fairly comfortable going ahead with a left PAO. You can see she's got a little bit of change at the femoral head-neck junction. We're a little worried about that, but nevertheless, we went ahead with a rectus-sparing PAO on the left side. And at 12 months, she presents on her left side with increasing pain, and subsequently underwent some imaging which showed a labral tear, and she had a subsequent hip arthroscopy on this side. She did not do well after that, and eventually went on to have a second hip arthroscopy for a capsular repair. So just this is the type of patient that we see not uncommonly, and here she is. Here she is now, I think, with pretty good correction, but she continues to have pain on her left side. So there's obviously now an abundance of literature that is showing really non-inferiority of scoping the hip at the same time as a PAO. So I think we can assume that this is a safe approach to addressing these patients. Paul Boulay, my good friend, beat us to the punch here with a very similar study that was published very recently, looking at his series of 200 PAOs at an average of 8.4-year follow-up, and he showed a subsequent hip arthroscopy rate of 7.4% at an average of at 3.9 years after PAO. What's interesting, if you look in Paul's data more closely, those patients who underwent subsequent hip arthroscopy actually did not improve markedly using the patient-reported outcome measures shown there on the left, and that is also, I think, very similar to the findings that we have seen in our study. So in conclusion, we have about a subsequent rate of hip arthroscopy of 5% at about 6 years with this rectus-sparing PAO technique. That technique has been very effective for us. It begs the question, should we be looking in the joint My bias is with 95% of the patients doing relatively well, I'm not sure that simultaneous hip arthroscopy makes that much sense to me. But obviously, it's being done, and we'll see increasing reports in the future, and I look forward to that. Thanks very much for your attention.